Hey everyone, and welcome to Holding the Line with Got Your Six Counseling. I'm Peggy, and this is Brittany. This is a space where we get real about the shit nobody wants to talk about: mental health, life, trauma, healing, and everything in between. Sometimes we get clinical, sometimes we get messy, but it's always honest. Quick reminder, this podcast isn't therapy, and it's not a substitute for professional care. We're not here to provide therapy, diagnose, or treat. If you're struggling with mental health, please reach out to a licensed provider. You don't have to go through it alone. We've got your six. We're just two trauma therapists showing up as humans first, ready to have real, unfiltered conversations about the stuff that matters. We're here to break the stigma, share what we've learned from both sides of the therapy room, and talk about the challenges people face every day, especially in the veteran and first responder communities. Whether it's trauma, burnout, relationships, identity, or just getting through the week, we believe that these conversations matter. They deserve space, and that's what we're holding the line for. So let's dive in.
Hello and welcome back to another episode of Holding the Line with Got Your Six. Today is season 2 episode and affectionately titled Live Laugh Lorazepam. Today we have joining us our very own Sabine Owen. She is our nurse practitioner, psychiatric mental health nurse practitioner. She is very loved by us and our patients because she gives us the wonderful medication. Before we jump in, I want to give a disclaimer, okay? Our conversation with Sabine today is not medical advice, right? She is not your provider. I am not your therapist because you're listening, okay? We're not diagnosing. We're just having a friendly conversation about some common misconceptions, misunderstood concepts of treatment, okay? Okay, now that we got that out of the way, we're going to jump in, okay? Mental health medication is one of the most misunderstood aspects of mental health treatment. I think we can all agree on that. Right. Some people believe it's like the last resort. Others are afraid that it might change their personality, become dependent on it forever, or be judged for taking it. Today, we're going to separate fact from fiction with Sabine. So, I met Sabine when we've been through a couple nurse practitioners, and Sabine has been the longest standing, I think, so far. You found us on Facebook too? I feel like everybody has found Got Your Six on Facebook.
No,
No?
don't. You know what? I just came across the job listing and then
Did you?
applied. Yeah.
Okay. So I met Sabine, I think, for the first time at the Christmas party, right? Like, I think we interacted maybe through group supervision and stuff, but like in person, I met her at the first Christmas party. And she's like super reserved and quiet. And I was like, oh, I don't think she's going to fit in here because we're all loud, like black cats, crazy. Our Christmas party is like the biggest event of the year. And she's just sitting, like taking everything in. And then all of a sudden it got quiet and she like blurted out this very like dark, inappropriate joke. And I was like, oh, okay. She's going to do fine here. And she has been fine. And our patients absolutely love her. I tell people all the time, I'm like, you got to go see Sabine. You're going to love her. And they do. They come back from their first appointment and they're like, she's amazing. She's great. Aww. And I don't know how she deals with some of the people we send her, but she does it with grace. So I wanted to have this conversation with her on our podcast for a long time. And when I first pitched it to her, she was like, immediately no.
Right.
I'm terrified. I don't want to do it. I don't know how you guys do the podcast. I love that you do it, but I'm terrified. And then she came back around. I was like, I got you. Question and answer sort of thing. So I'm very thankful that she has taken this leap to do it. She's overthinking all the questions I'm going to ask her. I just know.
I am.
Yeah, it's fine. She was overthinking the lamp behind her. I'm sorry. I had to say it. It's fine. But I think that we all heard, like, medication's the easy way out. Once you start, you'll never stop. It changes who you are. Maybe you've wondered that if taking that step means that you failed. That's not the whole story. None of that is true. If you had high blood pressure or diabetes or anything else medical related, you take medication for that. And this is the same thing. So before we jump into all that, I want to talk to Sabine a little bit about how she got into this field, right? What led her into nursing, why psychiatric mental health, what inspired her, and what she loves most about her job. So Tell us a little bit about you, Sabina. I know that is a gross question to answer. Tell us about yourself.
I know. I hate it. It's okay. Well, I got first interested in nursing. I was growing up in Germany, and I was attending this high school that was very much focused on like doing like work studies as a senior year. And I was placed in a hospital, and I thought I would hate it. And I went there, and it was amazing. I loved it. The patient interactions, like learning about different nursing interventions, disease processes. It was really interesting. I was done at the end of the day each day and just feeling like I've really made a difference. And that feeling just stuck with me. And so later on, I went to nursing school, got a bachelor degree in nursing. And after that, I worked at the Milwaukee County Jail, pretty large facility. We just at any time had just under 1,000 inmates in there, and you just see a whole large spread of mental health conditions, substance use disorders, people coming in and detoxing. And that kind of led me to wanting to pursue psychiatry. And then I went and got my master's, got licensed, became a psychiatric nurse practitioner. And then I found you guys. And yeah, I've been with Got Your Six ever since. And what I like most is basically when people come back and say, hey, the medication that you prescribed me last time, it's been life-changing. Just that kind of people's,
Seeing the change.
response to it. And yeah, exactly. So yeah.
I didn't know that you worked in a jail and did substance abuse work before. You and Dr. Rock have that in common.
Yeah.
I don't know that I could work in a jail. Like, it sounds chaotic, which parts of me feel like would be exciting, but also scary. So kudos, right?
Yeah. You never know what to expect.
Yeah.
It's very rewarding work, but very busy and very unpredictable.
Right. Also, you, Dr. Rock, that is right up her alley. And that actually surprises me about you, but also I feel like that makes sense for you as well. And your husband is also a veteran, so you landed here as well. And we won't even get into her husband. Total character, not someone you would expect. And meeting her, and you're just like, what? Okay. He's great. He's fun. He is always required at our Christmas parties. Maybe he'll be on the podcast one day, and you can meet him because what? Okay. I do know that her philosophy is creating a trusting relationship with her patients, which she mentioned, right? Like, seeing the change is something that keeps her going. And anybody that is her patient will tell you that, right? Like, I trust her. Whatever Sabina says is like gold, right? So let's talk about that. Why is that so important for you in your relationship with your patients when it comes to trust? Like, as a therapist, that's huge. If they don't trust us, we can't make progress.
Right. So it's the same thing for medication management. People show up in session, like for their first intake, they don't know anything about me. They don't know me. I'm asking them some really personal question. So they got to trust me enough to just open up a little bit, and so I can get a good picture of what is going on. And that is the basis for the interventions that I plan. But also then on an ongoing basis, the medication that I choose, it's like, how do I best say this? I'm sorry.
Fine.
And it's just on an ongoing basis, they have to trust me enough to know that I will try and do what's in their best interest, right? Like you said previously, there's a lot of misconceptions about medication management. I've heard people say, hey, you're just pushing medications because that's your job. That's how you get paid. And I want people to know that's not the goal. I'm really here to help you guys and to do what is best for you.
I think the misconception is like, oh, I'm going to go see Sabina or my provider, and she's going to write me a prescription and I'm out 5 minutes later. That's so far from the truth, because like, your first appointment with them is almost an hour, just like ours is. And your follow-up appointments are usually 30 minutes, sometimes more, depending on how long it takes as long as it takes. It's usually what I tell them. Because they're like, how long is the first appointment? I'm like, it's usually an hour when I'm pitching it to them, right? And they're like, well, what about after that? I'm like, it takes as long as it takes, depending on like what's going on. I think the trust is important because they'll come to me if they're seeing both of us. And I'm like, well, did you tell Sabina that? And they're like, no. I'm like, you have to tell her the truth.
Yeah.
You have to tell her the truth. Because if you don't, I will. If you don't, I will. She has to know what's going on if you want it to work. You know, the whole, I'm going to go see her for 5 minutes and then I'm going to walk out is so far from reality. It's so far from reality. And I think that like the medication, what people believe medication management to be is so different than what am I trying to say? I'm just going to move on. It's going to come back to me. I told Sabine before we started that I am out of my big mama ADHD medicine. So you guys are just have to bear with us today. we're all dogging life today. So my next question is, what do you hope people feel after their first appointment with you, like moving forward?
So I know that the first appointment can be a little bit overwhelming. Like you said, it's an hour long. I ask a whole lot of different questions. Sometimes I try not to dig too deep into any trauma history, but there are some pretty uncomfortable questions. And at the end of it, I just try and take whatever we talked about and try to consolidate it and come up with a treatment plan. And I hope that people walk away a little bit lighter and a little bit more hopeful, as in feeling that we're getting somewhere, right? That first appointment is just the first step. And even if I prescribe a medication, I can't guarantee you that it's going to work right away. So sometimes some more appointments and adjustments are necessary, but I hope people walk away feeling hopeful for the future.
Yeah, ideally, right? Sometimes just getting the appointment scheduled with you, us even, right? Like they already feel like, okay, I've got this. I feel good about this, right? And then after the appointment, maybe even much better. Maybe they haven't even filled the prescription yet. They're feeling a lot better about things, you know? That's that like pseudo effect of it moving forward. So we said a lot of medication management a lot so far. Now let's walk through what that actually means, right? So we have like this initial psychiatric evaluation that they do with Sabine. You know, maybe they get a diagnosis, which you would need to give them to prescribe them anything. After that, you're going to monitor them for the medication's effectiveness. You might have to adjust it. Maybe they have side effects. They're going to be following up with you. If they're here to see you and us, right? I follow up with you, you follow up with us. We call that continuity of care. What does all of that mean?
So
that's all medication management in a nutshell, right? Let's talk about what all of that means, like diagnosing versus prescribing.
Right. Okay. So yeah, medication management is not just like me handing out a pill. There's like all these components.
Right.
And obviously, the initial appointment is for me to make a good educated guess on what medication might work the best for you. Diagnosing just helps me put a name on it, right? Just based on all of the symptoms, I have to make a diagnosis. It's required for prescribing.
Yeah.
But overall, I just evaluate the individual symptoms and try to see what works for the symptoms versus the big overarching diagnosis. And then obviously follow-up appointments are really important. We usually give the medication a little bit of time to start working, especially like SSRIs. We know they take 4 to 6 weeks to build up. That's when they really show their full effect. And so usually I bring people back within that time frame, like a month later. And then we discuss what has worked, what has not worked. Have you had any side effect? And then just based on those responses, we make adjustments. So that's the follow-up is really important as well.
Okay. Y'all heard what she said, right? The follow-up is important. That it's not a one-time thing, that you have to keep coming back. It's an ongoing relationship. You can't just come in and get prescriptions from your doctor or Sabine and then be like, that's it, I'm done. You got to keep coming back. Because otherwise, like, you can't take it for a week and then be like, oh, well, this isn't working. I'm done. That's not how it works.
Right. And I talk to my patients about this too. I want them to have realistic expectations when it comes to the medications. Just because I prescribe something, it doesn't mean it's necessarily going to work. Everyone's body chemistry is very different. And if I take like a Prozac for one patient, it might be life-changing. And I prescribe it to somebody else and they're like, it's not doing anything. Yeah.
Unfortunately, that's how, and like, I'm not a doctor, but I have heard this. And because I've taken medicines, I feel like I know this. Most medications are based on, and you can correct me if I'm wrong, like some medications are based on your weight and such. Yes.
Can be.
And they're
Can be.
processed
So-
for different organs of your body, right?
Mhm.
Psych meds
Yep.
are a totally different beast, right?
Right.
So you have to kind of, it's like a process of elimination. We were having this conversation the other day. We were talking about, what was that? Trintellix, right? Because you were
Right.
like, I usually don't prescribe that unless I have to. One, because insurance is weird about it. And two, because it causes a lot of bad side effects and it doesn't always work. So we've talked about meds in this way a lot too. But personally, I've gone through a lot of medications that didn't work. It took me a long time to figure out what medicine was going to work. And then you find that one and you're like, I'm never letting this go.
I know.
Right?
Yeah.
You're like, I cannot change from this medicine. Right?
Right.
I have family members that have been through tons of medicines and they finally find the one, or they've maxed out on this one or that one, or they've tried thousands and they're like, I finally found the one. Right?
Nice. No,
So it
that's a
just
good.
depends on the person.
Yeah.
It's not like a blood pressure medicine that your doctor gives you and you're on it for the rest of your life because the first one that you tried worked. Maybe you get that lucky, maybe not. Maybe you try 100 different psych meds till you find the one. So
Yeah, let's
Anyways.
hope not. But yeah.
every person's treatment plan is individualized with Sabina, just like it would be if you were seeing one of us. It is different depending on the person. Unfortunately, with Sabina, it's a little bit harder to get it to work just right than it would be for one of us. We meet you where you are. Sabina's going to meet you where you are. So let's talk about what happens during your first appointment with her, right? I can say this from experience as being a therapist who sends people to her that they are terrified for their first appointment with you. They're so nervous. They're like, it's not universal, right? It depends on the type of person they are. But most of them are like, I am so nervous about my appointment with Sabine. I'm like, you don't need to be.
No.
But they're like, I don't know what she's going to ask. And I'm like, it's going to be very similar to the one you had with us. She will ask more medical related questions because she is a medical provider, right? We don't ask a lot of those medical questions, but she will. So let's pull back the curtain and give people a little insight into what happens during their first appointment with you. What kind of questions do you ask? Do you always prescribe medication during the first visit? And at what point do you decide if medication is not appropriate for them?
Okay. All right. So the first appointment, similar to you guys, I explore what their mental health concerns are, what their main complaint is. If it's depression, sometimes there's more than one thing going on. Some people are depressed and anxious and have sleep problems, and we will discuss all of that. So I'll ask targeted questions in regards to all of those. When did it first happen? And have you ever been treated for it? Are you on medications for it right now? How are they working? So I kind of do a review of like all possible mental health concerns. Have they ever had any hallucinations, delusions, manic type symptoms? And then when we've explored that, a little portion is like psychosocial. So do you have good social support? What does your living situation look like? And then we move into the more medical type questions. I need to know, do you have any allergies? And then like a review of body systems. Have you ever had seizures, head injuries? All those things are relevant to me. So just a review of like all the symptoms and what medical conditions you have. Obviously, if you are on any other medication. But yeah, that's basically the first appointment. I do not always prescribe medications on that first appointment. And I do have a fair amount of people coming to me and they're not sure if they want something or they have some hesitation. I'm always appreciative if people tell me like, hey, the idea of medications kind of freaks me out and this is why, so we can address that. But I try to make recommendations based on that first appointment and just be like, I give them the medication names and we do a quick overview of what they can do, how it could benefit them, what side effects there might be. And I'm kind of like, if you're not sure today, just get back with me later. If you change your mind, you can do some research on, you can look into everything. If you feel comfortable, we can always start it in the future.
Right. That's usually what I tell. I have people that are hardcore against medication that come in here, and at some point I'm like, look, I don't pressure you. I'm not one of those people. But at some point they get into the place where they're like, well, I want to talk to someone. I'm like, go meet with Sabine. You don't have to take medicine. You don't have to get her to prescribe anything, but it might be worth a conversation, right? Because I am not a provider. I don't do that sort of thing, right? could we talk about it? Sure. But I am not the one to give you that kind of information. I cannot adequately have that conversation with you like she could. So maybe that is some of those conversations that you have with people. It would be worth having that talk with her. So it is, I think, important to have those conversations with people that know what they're talking about, you know?
Yeah. And I don't want people walking away like feeling like I try to make decisions over their head or I'm like forcing their hand on it. I want people to have like agency and like knowing that they have full control over their treatment. Like this is supposed to be a partnership and we discuss where things will go.
What gets to me though is that like if they went to see a cardiologist or their primary care doctor, they would not have the same autonomy there, right? Like they would just give them the meds and they would take it and leave. And under any other provider, like except for someone like you or a psychiatrist, do they have the same doubts? You know,
Yeah.
If they're like, oh, I have a heart condition, let me take this medicine. Okay, bye, thank you. But for psychiatric medications, do people then stop and go, wait a minute, I need to consider the side effects? Or will I be on this for the rest of my life?
Mm-hmm.
Why is that even a question? If you are so anxious or so depressed that you cannot function, why are we having this conversation? Take the medicine. We can consider that later, right? Like, let's just get you back to life, all right?
Mm-hmm.
Anyways. Okay, so you said you don't always give medication. Sometimes they come back. Maybe they don't. Maybe they decide that they don't want it. They stick with therapy. We'll get to that in a minute. So then sometimes maybe they're listening, people are listening are like, okay, well, when is medicine appropriate? So we have a slew of diagnoses that we treat. Now, I don't know that there's anything that we don't work with here, right? Mostly we look at depression, right? I'm not depression, PTSD. I know, you know, PTSD isn't something that you diagnose and treat. I know that, right? Like you treat the symptoms. That's not something that we'll jump into technically. But what I want, so like depression, for example, right? People get saddies, right? Even baddies get saddies. We're looking at like sadness versus clinical depression, right? So like at what point do you or someone else, like at what point would someone then say, how do I know I actually need medication for this?
Good question.
Right?
Yeah. So I think sadness is just one component of depression and depression itself runs deeper than that. And I feel like you can kind of gauge whether you need medications or not just based on how it affects you on your daily life. Like how much does it interfere with your daily functioning? Depression can look a little bit different for everybody, but some overarching themes are often that people just have low motivation and low energy and have difficulty caring for themselves, difficulty getting out of bed in the morning and getting their day started, maybe trouble getting in the shower every day, or there's some kind of dysfunction getting their work done. So I would kind of say that if it interferes significantly in your daily life, like medications would be a good choice. And obviously, counseling is always such a big, important factor in it. But I feel like especially in depression, since it robs you of your motivation and energy to do things, it is hard to do the things that make you feel better. So yeah, I think that's where medication can be really helpful.
Yeah. In the counseling setting, depression is one of those things that's really hard to like get people to move in the right direction without meds, right? Can we do it? Yes, but it takes a really long time. I've done it, but at some point they're like, all right, I need meds.
Mm-hmm.
That's like hardcore CBT. We got to start charting this stuff down on a piece of paper, right? And they finally get the meds and then they start moving forward. And they're like, I'm so glad I started taking medication, right? Anxiety is a totally different beast, right? Most people with anxiety are so miserable. Like they know at some point they're like, I need some medicine, like right now.
Right.
You know,
right.
they usually know at what like threshold they need medicine, you know? They're like, yeah, I gotta talk to Sabine. I gotta talk to your nurse practitioner like tomorrow, like right now. When can you get me an appointment with her, you know? People with anxiety just know, you know? So that's not even, I don't even think I need to talk about anxiety, right? PTSD is another, I don't want to say questionable one, but I think they they struggle, people with trauma, I think, struggle internally on whether they need help or not so much that, especially in counseling and probably even with you too, on what exactly they need help with. Medication wise, especially, like, is it sleep? Is it my anxiety? Is it my mood? What are we actually treating here, and how are we treating it,
Right. And there are so many components to PTSD. And sometimes the treatment plan can shift from one to the other. You want one appointment, we might talk a little bit more about the sleep portion of it. And in the next one, we might talk about the mood a little bit more. We try to not make too many medication changes all at once, just because we have to kind of monitor whatever change we made last time. Has it rated any side effects? Is it working okay? But yeah, if there's multiple things going on, it can kind of shift from appointment to appointment. But I think also a lot of people with trauma don't realize that we actually have treatment options for nightmares. Sometimes people are like, what? You have something for that? And I'm like, yeah. So
like,
people are really grateful for those.
I
know. Yeah.
I have a couple that, well, I have more than a couple, but a few that take medications that didn't know that. And they're like, oh, I just have so many nightmares, I don't sleep. And I'm like, do you take anything? And they're like what? And I'm like, where you've been living under a rock your whole life? Like, what? I am one of those lucky people that take medications for nightmare, and it's phenomenal. But also, I think it bears mentioning, I don't want to say diagnostically speaking, but if you, how do I say this? Those symptoms overlap with other diagnoses, right? You and I were having this conversation this morning about the PTSDs, the bipolars, and the ADHDs, and how they all feel the same, and how some people have been misdiagnosed and they've been medicated for them all and still get no relief. And so if you feel like that's you, give us a call. We'll get you sorted, okay? But medicating them all is Sabine's specialty. ADHD is something that me and Sabine have had lots of conversations about, especially if you had trauma. Doesn't mean you have ADHD. You feel like you do, but doesn't mean you do, unless you had it as a kid. I'm just going to put that out there right now. If you have a trauma history and you're a grown up and you feel like you have ADHD, I'm here to tell you that you probably don't, unless you did when you were like 7 years old. Okay? I had this conversation with Sabine. I'm like, hey, this person feels like they might have ADHD. And she's like, well, I don't. She has a lot of feelings about ADHD. And as adults, it is a weird world in providers prescribing meds for ADHD because insurance and the federal government, DEA, has problems with that over prescribing, and they control it all. So you can go get tested. Okay.
Yeah.
We have someone that can do that here for you too. So reach out to us. All right. So Sabine, give us a idea. Well, for us as clinicians, therapists, let me just say this. Diagnosing, we use our little handy dandy Bible. We're on the DSM-5 CR now. Did you know that they're giving us a new one soon?
I did not.
I swear to God. Yeah, we're moving on to the 6th now. I think Peggy said that's 2027 or 8. I feel like they just want us just to keep giving them our money. But anyways, diagnosing gives us a idea of what box we can fit you in so we can formulate a treatment plan, and so we can bill insurance, okay? It does not say much about you personally. I just want to put that out. Sabine does diagnosing in her own way because she is treating the symptoms for you medication-wise. Sometimes your diagnosis might look different if you see both of us, okay? I just want to say that. Not that that matters. It doesn't mean anything about you. So I want to talk to Sabine about why diagnosing can be complicated for her versus why it's a little bit complicated for us. So can you talk a little bit about that for a second?
Like you said, diagnosing is important for having something to put on the bills and for, prescribing. Every medication needs a diagnosis on it, but sometimes I run into issues like, let's say somebody has been diagnosed with PTSD and they truly fit all the check marks. But then if I want to prescribe a very specific medication, especially if it's a more expensive one, I need to have my ducks in a row for insurance to cover it. So let's say, for example, Vraylar is approved for very specific diagnoses. And if I put PTSD in there, they're not going to approve it. So it needs to be like major depressive disorder or bipolar disorders. I have to follow within the realms of that. Or also, same thing for ADHD medications, that diagnosis has to be on there. So, yeah.
Guess that explains why some providers that I know, not you, do the whole alphabet soup diagnosing. Like they'll have PTSD, MDD, GAD, and all these. And I'm like, you don't need to do all that. Like the symptoms fit under this one.
Yes.
I mean, they fit criteria for all those things too, but they all fall under that one umbrella. But that makes sense now that if the med is only approved for this thing, that actually makes more sense because I'm like, that feels excessive. Why do you do all that?
I know. You should see my medication system. I have somebody who's on a lot of medications. They have a lot of diagnoses in there that kind of overlap, and it looks redundant.
Right.
But if somebody has an antidepressant, I put the depression diagnosis. But then later on, it's like they could benefit from a prazosin. It's FDA approved for PTSD. So I put PTSD diagnosis in there. So yeah, it makes a little bit of a mess of it, but yeah.
So it is for insurance prescribing purposes and not so much for actual diagnosis purposes, right? Like primary stuff.
Yeah. So when I treat, I try to really like hone in on like the individual symptoms that they have, try to find the best fit for it. And I'm not giving them a fake diagnosis. They still fit the bill. It's just like I'm putting more diagnoses in there than is necessary, so to speak.
They still fit it.
Yeah.
They still fit it. Yeah. So you mentioned in the beginning when you do like for the first session, right? You're asking about previous medications and, their history, right? Which is important for, prescribing the right medication that's going to fit them and not cause problems.
Mm-hmm.
So how do you evaluate like safety in previous treatment attempts when it comes to prescribing medication? Like I don't want to say why does that matter, but you understand what I'm asking when it comes to that.
So I always appreciate when people have the information together, like what they've been on in the past, because I ask, hey, why did you come off of this? And people might be like, oh, I was like a zombie. I was emotionally numb. I hated it.
Mm-hmm.
So I'm like, okay, we will never visit that one again. So I have a little list of which ones did not work. And then the medical history is important too. There are some contraindications to certain medications, like say somebody needs treatment for ADHD, but they have like a heart history or untreated high blood pressure, or they're untreated bipolar. I'm leery about it. Do I want to give them an Adderall?
Right.
Or somebody with a seizure history should not get Wellbutrin. Just some kind of having all the information together to see, are there any contraindications what I'm considering prescribing them?
Right. That's like the medical side of it too, that you're considering. That's not so much just like, oh, let me throw some medications at you.
Right.
For sure. So Sabine mentioned earlier about how important not just throwing medicines at people, which she doesn't do, to be clear. It is to also have therapy in addition to medications. When used individually, we know that medication and therapy are similarly effective. We know that. Combining them is has the strongest outcome, particularly for moderate to severe depression, which we kind of mentioned a minute ago. Combined treatment increases remission rates from approximately 34% with therapy alone to 46%. Patients receiving both treatments are twice as likely to improve compared to just medicine alone, which actually surprises me a little bit. Up to 30% of individuals with depression may not respond to initial treatment, making medication adjustments a normal part of care rather than a sign of failure. Let's say that again. 30% of people with depression may not respond to initial treatment, which means you got to go back and get something different. 30% doesn't sound like a lot, but it actually is a lot. Translation, medication reduces symptoms. Therapy helps people understand themselves, develop coping skills, and create lasting change. Together, they frequently provide the strongest outcomes. Y'all. So, how much does... Oh, okay. Actually, I'm going to skip it. So, you guys know we work with trauma, PTSD, and first responders. Therapy doesn't cure PTSD. There is no cure for PTSD. We have some really good interventions. Sabina gives really good medicines. And Sabina mentioned, there's medicine for nightmares. She can give you some medicine for your anxiety and depression and stuff like that. But I want to bust this right now. Everybody knows if you take meds and you've ever been given meds that benzodiazepines like Valium, if you've been taking Xanax, you should just try to talk to somebody about not taking that ever again. I'm just going to put that up. Such an awful medicine, right? I think we both can agree on that. What's another one? Valium, Klonopin, Ativan. Why are they not recommended for long-term treatment anymore?
They used to be like the mainstay of treatment for anxiety because they do work. Like in the moment, people have, if they have massive anxiety, panic attack, in that moment, there's almost nothing that works better to bring it down. Obviously, people really appreciate that effect, but it can be a slippery slope into a dependency on it. If I ever do use it, I do tell people like, hey, try not to use it every day. You don't want to be dependent on it. And just long-term has some nasty long-term side effect, particularly memory loss. So they found in studies there's some in long-term benzodiazepine use, there's some pretty nasty memory dysfunction there. There are other options out there. Ideally, we try to work with medications that prevent anxiety from coming on in the first place. But again, everybody is different, and some people are already on SSRI or a Buspar, and it's supposed to bring the anxiety down and prevent it from happening, but it's not always the case.
Right. And sometimes it peaks and you need something to bring it back down. However, in the therapy world, especially if you're going to engage in something like EMDR, it is actually frowned upon. Like benzos actually help, like, I don't want to say prevent it, but it actually makes it harder to reprocess memories like that if you've been taking benzos long term. Not that we can't, it just makes it harder because when we're doing EMDR, you get very activated because we're going back. And so if you've been popping benzos for years, when you get activated, well, now you're really activated and you can't pop it. So it actually makes it a little harder for us to get you moving forward if you've been doing that. But that's just a thing, we can help you manage with some stabilization. But in the medication management world, it's pretty hard to find a provider that will give you a benzo these days. And if you do, you're pretty lucky, but maybe be moving away from that sort of thing. So side effects, let's talk honestly for a second before we, move towards the end here. How, I know in taking them and hearing things, there are some super serious side effects that can occur, right? There's always that one, if you experience suicidal ideation, blah, blah, blah. There's the weight gain, there's sexual side effects, the emotional blunting you mentioned earlier, which is pretty common. I think it's some of the, like Seroquel, like some of the antipsychotics is pretty common. I think some of those are the big ones. And then why communication with you about these is so important.
So I usually give people kind of an open door. In that first session, I give them my contact information. I'm like, hey, if you notice any side effects, please do reach out. Sometimes certain mild side effects can be expected. Somebody might be a bit dizzy or drowsy or have a headache like that first week or two after starting it. Some of them can go away. So I tell people not to get too discouraged if it's manageable to push through it. But also, if people have concerns, questions, they can reach out to me. Overall, serious side effects are still pretty rare. So I don't want people to get too freaked out when we're talking about suicidal thoughts and whatnot. That's a small fraction of people who develop that. So yeah, to just keep in mind, really serious side effects are rare, but we do have to put the disclaimer out there just so people know what to do in case it does happen.
Right. In the 3 years I worked inpatient psychiatric hospital, I only ever saw one person in 3 years who had a side effect like that from an antidepressant. I think those are pretty good odds, right? I mean, I know that was in one area, but still, in 3 years working inpatient hospitalization, one person who had, suicidal ideation, and she didn't try anything. She was just like, I'm feeling suicidal, which is really weird because I just started this medicine. And they switched the medicine and she was fine. And so like you said, most people don't experience every side effect that is listed, which would be weird. Super serious side effects are pretty rare. I've had weird, I think when I was taking some pretty hardcore ones, I think I took an antipsychotic one time for mood. I did have weight gain, which leveled off after I've been taking it for a while. Sexual side effects are pretty annoying, which you should be telling your provider about so you can switch it. Because if you weren't homicidal before, you will be after that.
Right.
Emotional blunting, some of that should be happening if you're over emotional. Also have that communication. Those inserts that you get, or if you're Googling it, are required. They have to release those to people. And if you have concerns about it, again, have those conversations. So I feel like we definitely have to talk about this. The questions that people Google, I feel like we're cutting in and out. Are we good? Okay. Can I drink alcohol? What happens if I miss my dose? Can I just stop these medicines when I feel better? No, you can't. Are the generic medicines just as good? Can I take these supplements with my medicines? Please. And then my most favorite, why can't I just stop these? I'm feeling better now. Can I drink alcohol with my medicine? Probably not. What do you say?
You shouldn't. For legal reasons, I have to say no.
Also, this is not legal advice.
And the medication, they both meet in the brain, and it's a little bit unpredictable what they can do. Something that I have heard is that people might get intoxicated quicker on the combination of both, or accentuating side effect. And the alcohol can also cause the medication not to work well. So that's not to say that many people still do drink to some extent, but it's always advisable to stay away from it as much as you can.
Agreed. I can tell you from personal experience, don't do it. Don't do it. You'll regret it. You'll get very sick. What if I miss a dose?
So if it's within the same day, just if you notice you forgot your morning medication, you can take it in the evening, right? If it's already the next day and you're due for your next dose, don't double up on it. But usually one missed dose is not going to really derail you, just because the overall levels in the brain matter, and just one missed dose is not going to dip it too much.
Right.
Should be fine.
Generic medications are the same as the name brand, yes?
They're supposed to be. The active ingredient is mandated to be the same. Every now and again, somebody might come back and say, hey, the name brand worked differently for me than the generic. And in situations like that, I'm open to writing for the name brand. But in general, I think generics are just fine.
So can supplements interact with your medications?
Yes, they can. So if it's any let's say vitamins or minerals, if people take a vitamin D or something like that, that's usually fine because it comes from a nutritional thing.
Right.
But if it's herbs, like St. John's wort or ashwagandha, or I think the most significant one is methylene blue that people buy over the counter, they often have a similar effect than the SSRIs. So they can also raise serotonin in the brain. And if you take an SSRI and then the herb on top of it, it might be too much of a good thing. So can cause serotonin syndrome.
I'm so glad you said that. A lot of people don't know about serotonin syndrome, which I don't want to get into, but it's an important thing to bring up. So if you don't know what that is, Google's your best friend. And if you have concerns about it, talk to your provider, because we're not offering medical advice here, okay? This is the most important thing I want to get into. Why can't I just stop my medications all of a sudden, Sabina?
Okay, because our brain gets very much used to these medications, especially if we're talking about an SSRI. They raise their serotonin level, and that's then what the brain is used to. And if we suddenly pull it out, for one, whatever symptoms we were treating before can come back with a raging force. And then also it can cause withdrawal symptoms. So people will feel really sick. It's not dangerous per se, but they will feel really awful, nausea, tremor, headache. So sometimes people describe brain zaps. So people will be pretty miserable if they stop too abruptly.
Right. I always tell them, and we're in that, and I tell them the same thing. In severe cases, depending on what you're taking, You can have seizures. Like if you're taking benzos, you can have seizures. You can have suicidal ideation. Like we don't want to have any of that. Like, please stop. And they're like, well, I'm titrating down. I'm like, are you a doctor? Do you have MD behind your name since the last time I saw you? No. Okay, then. So let's not do that.
Yeah, and if somebody ever wants to discontinue medication, I'm open for that conversation as well, and I will help them safely titrate down. But
right, because you are your own
get me on
human.
board.
Right, you're your own human. If you want to stop your meds, even if your provider disagrees, you have that right to just stop.
Yep.
Right, so they will work with you to figure out a plan to titrate you off, and that is your right. So they're not gonna be like, no, you have to keep taking this. Please don't just stop your meds. All right. So as we're finishing here, I love when, I don't say I can convince, but when people are taking medicine, I love it. When they're taking medicine and they see Sabina, it makes our lives so much easier because she sees them and then she might not see them again for a month, but I see them every week or every other week. So I see them much more often than she does. And so if they're a dumpster fire in my office and they're like, oh, I haven't been able to fill my meds, or I ran out, or I missed my last appointment with Sabine, so I haven't seen her in 3 months. And then I'm like, or I'll pick up my text and I'm like, wait, I get you to see this person, like ASAP. And she's like, oh my gosh, I'll email them or I'll call them, right? And it makes our lives easier. It makes their lives a lot easier because we have that communication, that continuity of care for that patient. So I think that's so important for our patients, and it makes their lives a lot easier. So I love the relationship that we all have here as providers. And I think our patients definitely enjoy that too. So I'm like, I'm ratting you out. When you leave, I am calling Sabina. They're like, no. And I'm like, it's done. That ship has sailed. I already texted her. So I don't know if our patients love it, but I definitely love it. And I know Sabine does. So we have had some really fun patients together. So I think that combined treatment is super beneficial for us here. I don't know. I mean, I know that you have patients that you see that don't do therapy with us, and that's fine. Maybe they have therapists somewhere else, or maybe they're not doing therapy at all. If that works for them, that's great. Like we just said, therapy and medication together work the best. So take that for what it is, I guess.
Right.
So I thank you all for listening today. I thank Sabine for joining us, even though she was super nervous about it. It wasn't that bad, was it? It wasn't that bad. Also, I think I said saddies get baddies, and I meant to say baddies get saddies earlier. Maybe I said it right. I don't know. Okay. I've been thinking about that for the last 10 minutes. I think I said it wrong.
I don't remember.
Anyways, I don't either, but I'll know when I rewatch it and Peggy edits it. If I said it wrong, I just said it right. So anyways, thank you for listening. Join us for our next episode and for other things we have in the works for Trauma Talk with the Doc. All the things, like, share, and follow, and join us for our next episode, and we will see you on the next one.
That's all we have time for today, everyone. We want to thank you for tuning in to this episode of Holding the Line with Got Your Six, where we are just a bunch of therapists who talk about the shit nobody else wants to talk about. We hope you got something useful out of it, or at least made you feel seen. A special thanks to our guests for taking the time to join us and share their unique perspectives and life experiences. New episodes drop every other week on our YouTube channel, Holding the Line HtLwGY6. Be sure to follow us on Facebook and Instagram, where we post more helpful info, dark humor, and more of the shit nobody else wants to talk about. In the words of someone wiser than us, go forth and do magical shit, everyone.